Thanks, Mark. That was really fantastic. It's just so good to kind of see you developing systematic answers to those open questions about stability that have been around for so long. So our next speaker is Nicolette Graham, who is the clinical pharmacy lead for the Queensland Children's Hospital. She's the clinical pharmacy and antimicrobial stewardship lead, and she's passionate about paediatrics, in particular infectious diseases, therapeutic drug monitoring, and equity of access to appropriate paediatric medicines. She's got a research interest in AMS and also sepsis and OPAT and hospital in the home. And she's gonna, I guess, tell us about an area that we sometimes forget to talk about when we get adult physicians together, or adult specialists from a variety of fields, but we're going to hear about kids and paediatric considerations.
Thank you, Ben, for the introduction, and thank you to the previous speakers for a very interesting topic and lots of interesting discussion coming. So a little bit of a change of pace. Yes, as Ben has mentioned, we are going to talk about the little elephants in the room, our paediatric patients, and why in OPAT and HITH we've got some special considerations, and why when one size for OPAT and HITH doesn't always fit all in our PEDS population. If you'd like to join the poll, if you've got your smart device available, if you want to type in that link on your screen, pollit.com/antibiotics L889, we've just got 2 poll questions that will come up as part of the case discussion. So what we'll be covering in the next 15 to 20 minutes, just a little bit on AMS and paediatric OPAT. I think Kate's given us a really excellent introduction into what those strengths and considerations between AMS and OPAT and HITH should be, and what the next steps are in that field. We're also going to have a little bit of a look at some of those special considerations for successful delivery of OPAT in children. And then some of the lessons we've learned along the way. So when we look at AMS and paediatric OPAT in particular, there's often a little bit of a tension between convenience and appropriateness, and it can be really hard to get the balance right. As Kate has pointed out, there's some real benefits in terms of quality of life for patients who require prolonged courses of intravenous therapy. But often we think about which antibiotics we practically can send them home on, and sometimes there's a little bit of a discussion around broad versus narrow spectrum and what we can actually achieve in our HITH or OPAT setting for our patients. Balancing that with choosing the best drug for the patient, so the best drug for the right bug and the right condition. And also, as both Kate and Mark have alluded, the optimal drug dose and exposure, as well as stability. And then in terms of our discussions at the beginning, we discussed the OVIVA trial, IV to oral switch, and which route would be best in our patients is often at the front of our minds when we think about HITH and OPAT. So I'd like to introduce you to a young patient, meet young James. He's a 6-year-old boy weighing 30 kilos. He was brought in by his parents to the emergency department recently with some fevers and left knee pain. He's got quite a swollen and tender to touch left knee, and he hasn't been weight bearing for the last 24 hours at home. Mum mentions that there's no history of trauma and there's no visible skin lacerations or lesions. He has had a history of a viral upper respiratory tract infection over the last few days. The team decide to admit him, place a peripheral cannula, take a blood culture and necessary bloods, and send off a respiratory PCR. They perform some imaging, and the orthopedic team comes and reviews him in the emergency department. On the MRI, there were some interesting findings, including intramuscular abscess, some myositis, in particular associated with the left hip and the long bones, and concerns of associated osteomyelitis in this patient. On imaging, they were happy from a radiology perspective that the left knee seemed to be normal. So we've got a couple of options: pip-taz, ceftriaxone, cefazolin, Fluclox, vancomycin, or in case you have another choice, none of the above. I'm just going to swap screens for a second. And so we've got some interesting responses coming through and a little bit of peer influencing happening as well. So a couple of choices. So vitamin P seems to be a popular option. Some cefazolin coming through, and then Fluclox looks like might be our front runner at the moment, and a bit of vancomycin coming through. So as Ed pointed out at the beginning of the session this evening, there are some common causes of bacterial osteomyelitis in children in particular, and we can break that up into a couple of age groups in terms of the bacterial etiologies. And as we can see for our particular patient, for James, we think that the most likely cause in terms of microbiology that could be driving this disease process could be Staph aureus or MRSA, group A strep, Strep pneumoniae, Kingella, or Haemophilus influenza B. Now, as part of the history, Mum mentioned that James, in fact, has received all of his immunisations and he is up to date and considered HITH immune. There is also no history of any MRSA risk factors, impetigo, boils, or any at-risk patient groups that James belongs to that we need to consider in this setting. So at the moment, we're not too concerned about MRSA risk factors as such. So culture results come back, and we're happy to report that as a Staph aureus cultured on blood for young James. His respiratory PCR comes back, not detected for SARS-CoV-2, and rhinovirus popping up on his MPA. His admission CRP is increased at 112, and his ESR sitting at 15, and his baseline ELFTs are unremarkable. And as we can see, we've got a methicillin-sensitive Staph aureus that we're dealing with at present. After reviewing the imaging, the orthopaedic team felt that there was no reason for surgical intervention at this point in time, and that intravenous flucloxacillin would be an appropriate antibiotic to start young James on. So jumping ahead in time, we're now day 3 on the ward, and James is starting to weight bear, and his younger brothers have come to visit him. And he's definitely keen to get home. He's now been afebrile for 24 hours and his repeat blood culture is negative to date. His appetite's definitely improving, and you note that he's tolerating his oral analgesia, and his CRP is definitely trending down. So given everything we've learned this evening, just a straw poll, would you like at this point to continue IV therapy, or would you consider changing him to oral antibiotics? Or are you still a little bit undecided? Definitely some interesting considerations. And certainly from our team perspective, reviewing this patient in discussion with the orthopaedic and the ID team, there was definitely some benefits both for continuing IV therapy as well as for swapping to oral therapy. But I guess the one clincher for James's management at this point in time was considering his staph bacteremia. And so in the last couple of years, there's been a seminal paper in the Lancet ID published by an Australian group, ANSPID ASAP, led by Brendan McMullen and Dr. David Andreessen, that looked at antibiotic duration and timing of oral switch in bacterial infection for children. And as part of this systematic review, they've developed some guidelines to help guide clinicians to make decisions around the best timing for oral switch, but also the best duration for IV therapy if there's associated complications with such as bacteremias. And as we can see, for acute osteomyelitis in patients where it's considered a complicated disease, where there may be associated abscesses or bacteremia, that there would be a minimum IV duration course. And in this case, the duration would be 4 to 7 days IV with an oral tail as an oral switch after for appropriate antibiotics. So after ID consult and a HITH review, the decision was made that he needed a few extra days of IV therapy to ensure that we've satisfactorily treated his bacteremia with a follow-up review in orthopedic clinic and ID clinic, reviewing his CRP and his clinical progress, and then discussing a IV oral switch on day 8 to complete a 6-week course in total of antibiotics. And in this case, the antibiotic of choice was cephalexin, good oral bioavailability, good oral dose, but also better palatability, because as we know, fluclox suspension is probably one of the worst tasting antibiotics. Now, this is just one scenario. There's definitely clinical decisions that could have been made one way or the other in terms of duration of therapy. But for James, there was consideration to continue this on HITH. So the next step is for us to consider how we're going to go about providing HITH. So as part of our HITH service here at the Children's Hospital in Queensland, we introduced our OPAT and HITH model firstly in our cystic fibrosis patient cohort. And as part of this introduction, we performed an audit on our elastomeric infuser performance. And what we found after reviewing especially piptaz and ceftazidime elastomeric devices, that there may be some impact of the type of IV access on the optimal infuser function and delivery of antibiotics, excuse me, for our pediatric cystic fibrosis patients. And so as part of our audit, retrospective audit, not a highly powered study, we just had a look at different devices that our patients had in situ. We looked at different antibiotics and concentrations they were receiving, and we audited the amount of antibiotic delivered by way of looking at the percentage delivered. Our nursing practice was to weigh infusers at the start of connection and then at the end of connection, and we were able to calculate the amount of drug delivered in that 24-hour period. And what was really interesting is that we definitely noted a significant variability in our infuser function. And certainly for some cases, we could describe some patient factors that may have influenced the infuser function, but there were a large proportion of this cohort where we couldn't quite explain why we had such variability in antibiotic delivery via particular devices, in particularly peripheral cannulas in young children, but also a new type of PICC line that had been introduced in the 6 months preceding our introduction of this intervention in our CF population. And so after some further analysis, in particular, it showed that for piperacillin tazobactam, we had quite significant variability in infuser function and delivery of drug, the higher the infuser concentration or drug concentration in the device. And what we basically found was for patients on maximal dosing and cystic fibrosis, they often ended up having less than 75% and less than 50% of their drug delivered over a 24-hour period, which is not ideal. As part of our study, at the same time as these things happen, a randomized control trial, very well designed, was being introduced by our vascular access service at the Queensland Children's Hospital, led by Tricia Clyden and Amanda Ullman. And they were introducing a brand new type of PICC line with some clear benefits in our pediatric population. This included a technology called Indexo, which reduced infection risk and thrombosis or occlusion risk in patients with this PICC line in situ. And they were looking at this against our standard PICC lines that were implemented. And that was done in randomized controlled fashion between our 2 cystic fibrosis wards within the facility. The results that they published in 2018 showed a clear benefit for patients in terms of complications, a much lower rate of thrombosis and complete occlusion in patients with biflow PICs compared to standard PIC lines. But unfortunately, as part of this study, secondary outcomes in terms of antibiotic elastomeric infuser function was not assessed. And so for us, in terms of pediatric considerations, and there is quite a few factors that we need to consider, but specifically in terms of types of IV access, that actually plays a really important and a very big role in our pediatric population. We also know that children can be quite active, and choosing IV access device that's going to be safe for them to have at home while their antibiotic therapy is being delivered is part of that consideration. And so one of our manufacturing partners has provided some really cute little backpacks for the children, which store their elastomeric devices or infusion pumps to allow continuous antibiotic infusion delivery in the home setting. And we've really had great success in the younger children with that particular setup. But when we look at drug stability, IV access options, and what type of device we use, this diagram or matrix is just a general guide as to, based on the current evidence, how we would approach our antibiotic choices and device choices for our patients. So after our cystic fibrosis patient audit was reviewed, we ended up deciding that we required a second delivery device option available in our hospital to be able to deliver continuous antibiotic infusions. And so we've moved for, in particular, peptides, high dose peptides, to using an IV bag with an ambient pump to deliver that continuous infusion. We've had really great patient satisfaction with that particular device, and we've definitely seen a much higher percentage of drug delivered over a 24-hour period in these patient groups. We still use the elastomeric device in our smaller patients on lower doses of peptides, and we see quite optimal delivery in those patient groups. Obviously, there's lots of controversy around stability of drugs, and certainly for us, as Kate pointed out, in Queensland, we need to consider our summer temperatures and the environment in the home in terms of what drug we deliver over what time period. And so in our cystic fibrosis patients in particular, cefepime we would only do as a continuous infusion during winter time. Moving into summer, we start needing to look for secondary options or actually changing to a twice daily delivery model. When we think about delivering an alternative OPAT or modified HITH model, we've done that for our ceftazidime and our cystic fibrosis patients. And in particular, we do that by HITH antibiotic delivery for the first dose in the morning with erythromycin through an Intimate device as a bolus infusion over half an hour, and then training up the parent to administer dose 2 and 3 of the ceftazidime during each day. And we've had high satisfaction rates in those patients where peptide is not suitable. So in conclusion, pediatric OPAT is definitely a team sport. It's really important to think outside the box if things don't quite go to plan, and do some detective work. There's often a really good reason why things aren't quite panning out. There's lots of very willing and able clinicians working with you and your team outside of ID and AMS. Think about your environment, think about your medication properties, as Mark has shown us in his talk, and also consider the type of IV access devices that you use, and particularly in small patients where small French size devices. And remember, parents and carers can be great advocates for your patients. Thank you.
Thanks, Nicolette. That was really, what's going on there? That was a really interesting talk, and I think you make a really good point about there being, so much more than the antibiotic, the dose and the stability that you need to think about in the pediatric and probably also the adult setting as well. Now we're up